All right, good morning, everybody. So what I love about today is that the topic of final hours is why I do what I do. Because there is no better time for me in hospice than to sit by bedside when somebody's comfortable and to hear the families reminisce and laugh and joke. That is hands down my favorite part of my job. And so getting there sometimes can be challenging, right? Getting to that comfort, getting to that peace. I'm going to need one more nurse up front. Just throwing that out there. Come on. I'll take you, Carl. That's cool. All right. So we started, I don't know if you guys remember, the very first slideshow, there was the quote, life is pleasant, death is peaceful. It's the transition that's troublesome. The same thing applies here, right? So as long as we can work through that transition with the patient, with the patient's family, then we can do a lot better things. And I invited some nurses to sit up here with me and some CNAs to sit up here with me, because at the end of the day, that's a lot of times those are the hands-on people there at the end, right? Social worker and chaplain are doing their thing. They're setting the stage. They're getting the families ready. That's the hands-on piece, a lot that we'll talk about today. So one of the other things is that we are exposed to death more than obviously your average Joe, right? Nurses and CNAs in general are exposed to death more than the rest of the healthcare field. And so at times that can be challenging. That can be hard to be part of that, that experience with the families. And sometimes it's hard on us as much as it is the families, depending on our connection with the patient. So being able to work through that ourselves is important as well. So for me, it's that peaceful point that helps me move on to the next one. So as we talk about those last few hours, just a reminder that it's a physical process, a psychological process, a social process, and a spiritual event. And so as we plan and we do those end of life plans, that's what we want to touch base on those. So I'm going to pull in a chaplain or a social worker too, as we set the stage as well. All right, so again, we have the most real experience with death, where they're watching that final breath. The other part is that we're helping the family prepare, right? We're helping them prepare to say goodbye. We're helping them to complete those end of life closure tasks. The chaplains and social workers are setting those up, and then we're watching those resolve towards the end. As we approach this, we want to make sure that we have those interdisciplinary competencies, right? That empathy. And I think I talked about this before, but I think maybe 10 or 12 years ago, I'd gotten to the point where death was just a mechanical process to me, where patient died and I honestly felt nothing. Like I was cleaning the body. It just didn't affect me at all. And so my remedy for that is I took his widow to dinner or to lunch every Friday for the next 2 years until she couldn't anymore. And so she's like 98, really cool lady. But that helped me remember that we're taking care of a husband, a daughter, a son, we're taking care of people. And so I had lost that in myself. So being able to have that empathy and still be involved in that. Being positive in whatever situation we're in, right? Nobody likes a nurse to come in and like, oh, this sucks. What are we going to do? Right? That is not the tack to take. Genuineness, right? They want you to be there, trustworthy, giving them good answers, attention to detail. So paying attention to the room, what's going on, what do we need to change, what can we adjust? And then the big things are being with and then bearing witness. From a bearing witness standpoint, maybe from one of our CNAs here at the table, what does that mean to you guys when you're there?
To me, it makes me feel like being there right when they're dying. I don't know, it's like that closure I get.
Okay, so closure for you?
Yeah.
Okay. And,
to be
and
there at the very end.
Okay.
I get closure and I get to be there with them so they're not alone
Mhm.
if they have no one there.
so being there when
And-
no
and-
one else
and
can.
That happened a little, not too long ago, where the staff was there and we were waiting for the family to come and the daughter didn't want her father to pass alone, and we reassured her, that's not going to happen. We're here with him.
Mhm. Perfect. So the other part of bearing witness, did you have something else too? No. The other part of bearing witness to me was, if for one, that's a person, that's a human being, right? And so being there and acknowledging that life has been a big part for me, especially towards that end.
Mhm.
So obviously no typical death. Everybody dies in their own way. That hit a nerve, Gary.
Yeah.
So no typical death. It's their own way on their own time. And sometimes patients will pick it. Like, I'm done tonight. One of my favorite stories, this guy with cancer, 96, and he had walked 6 miles every day up until he was 95. And then the cancer kind of slowed him down a little bit. He was a CEO of Simplot for a while. And his son told me this way. He's like, he sat there and it was like a board meeting. He's like, okay, I'm going to go in there. That was his last words. Love you guys. I'm going to go in there. And he went in, laid down and died.
That's cool.
It's like, good for you, man. So that was cool.
Yeah.
So we got to understand their own culture, right? It's not the family's culture. It's not our culture. It's the patient's culture, how they want it to be, their own beliefs, their own values, their value systems. And then one of the challenges that we have is when families are excluded from that death process, right? There's times where families feel like they don't want them there. And that's true. Like, they're going to draw into themselves. I want one person there. And maybe that one person isn't the person that wants to be in the room. And that's challenging sometimes for the family. But that's where we get that death plan. That's where we come up with an idea of how we're going to take care of them the last few days. When you can't speak for yourself anymore, how can I, as a hospice nurse, speak for you? Who do you want at the bedside? What music do you want playing? What do you want the room to look like? You know, those types of things that we can talk through with our patient and make sure that we have a good plan for them when they can't make those decisions anymore. And so we're going to talk about where, with whom, and how, right? For my mom, it was a lot of Dilaudid. That's all she wanted. And her sons are. But that's where we want to talk to people about what they want. I got double buttons going on. I apologize. Not gonna let me do it. Okay. So when we look at an open and honest communication, I'm going to try to go back one more time. Okay. So open and honest communication, we want to convey that caring sense of compassion, right? We want to make sure that our tone matches the rate and tone of the room, right? We're not coming in as a bull in a china shop. We're matching and hopefully bringing down the rate or temperature in the room. Sometimes that can happen. We try to be that calming voice. We want to make sure that as we're not using overly complicated wording. Sometimes as medical professionals, we can use big words to make ourselves sound smart. And we want to throw in those words at the appropriate time so we do sound intelligent and know what we're doing, but we don't want to overwhelm people with it, right? We want to make sure that we're having that open, honest communication, but we're using words that everybody can understand. I had the privilege of taking care of somebody, their granddaughter happened to be an internal medicine physician. So I'm like, okay, what terminology am I using with this patient and how am I going to use it? And so I may have adjusted a little bit and changed the way I communicated with her and then with the mom who was just there and just was not ready for what was going on. Because we don't want to be overwhelming. We don't want to overload them. Sometimes you'll get the patient say, am I dying? Right? They already know that, right? Yes, and we're getting close, right? What kind of, have you guys had that question?
My mom.
What was your answer?
I said, yes, you are.
Okay. And you'll have families like, no, you're not, no, you're not. And
Yeah.
somebody like, yeah, it's happening tonight.
Yeah.
We're checking out. When we talk about somebody we talked a little bit about this last week, the difference between a child on hospice, a mom of 6 on hospice, and an older person on hospice, right? We internally can assume that that older person has closed out their life events and they're set. That is definitely not always the case. I'm trying to think if it's like a 50-50 split, but still towards the end of life, even if you're 80, you haven't completed, some people haven't completed those tasks of life and they still feel like a rush to get those things done. So we can't assume that they've just addressed their own mortality. Some people still think they're going to live forever. And that will be some of the challenging, because the daughter is going to feel like they're going to live forever too. So we want to make sure that we acknowledge that and walk through that with the family. We want to be able to help the positive influence, right? So if you guys have your Wi-Fi on, if you could close that out. So let's go to the 2 roads of death. We talked about this in March. So what we hope for is this normal, sleepy, lethargic, attended, semi-comatose, and then comatose, right? That's our hope. And so I will always communicate this with the families. This is the way that these things could go. We hope for this one, but let's prepare for this one just in case. This is what this is going to look like. The restlessness, the confusion. And when you specifically talk about diagnosis, right? So what kind of, maybe Brittany, if somebody has a brain tumor, what kind of things are you're trying to prepare the family for towards the end of life?
I think worst case scenario is seizing.
Okay.
Constantly.
Out of control seizures. Okay. What else?
Maybe some hallucinations and delusions and terminal agitation as well.
Terminal agitation, personality changes, right? It's not you, it's the tumor, right? Those types of things. And that personality flip in a like a glioblastoma or something can be significant. The dementia is a slower transition, but there's some personality changes in there, but, and then the medications too. Like you put somebody on Dex that's sensitive to it and they're a raging rage monster, right? So we want to make sure that we can talk the family through this, some of the side effects of medications. Carl, COPD, patient says, I don't want to suffocate. How do you talk through that?
I go over the morphine and how that can help alleviate some of the stress on the breathing. Just try to reassure him that, oxygen and just relaxation will help to some degree with that.
Okay.
But in reality, they are going to have some trouble.
And so do you find, when you say you're going to feel short of breath, do you find that they recoil from that, or do they?
I think I don't think I've had anybody recoil from it. I think most of my patients that have had COPD, they understand because they've had it for a long time, because COPD lasts forever. Yeah. Typically, and so they realize that, and I think they accept it.
Okay. So patient just had 3 weeks ago. Couldn't do anything about the terminal secretions, right? And his daughter, in kind of a quiet voice, can you please make this stop? That was her request. And what was my answer? I don't know. I will try. And so we actually had him almost in a prone position before we got any relief to the terminal secretions. And so it made me think, do we need to adjust how we care for people? But he had a lot of facial edema at the end. So something to think about. If you got to go prone, go prone. But to avoid that suffering sometimes that the family feels, patient doesn't care, right? But the family can feel that. So when we want to make sure that we talk through the confusion, the tremulousness, hallucinations are going to happen, something as wonderful as angel reaching, right? And if they're religious, they're reaching out for Jesus or reaching out for a loved one, whatever, take that every day of the week. If they're not, morphine's just making them happy. Don't care which one it is. Delirium can be very challenging. A hyperactive delirium can be very, very challenging for the family. Myoclonic jerks can be unexpected. So we want to make sure that we talk to the family through that. I told you my uncle passed away on Monday. Monday. And I told you that the hospice had, my opinion, get way too much Haldol. And so I was telling the family, back off as much as you can, especially if you start seeing jerking and stuff like that. So I was trying to walk her through. But being able to understand what's causing the myoclonus, right? Is it the medications we're giving them? Probably, morphine, Haldol, both are going to do that. And then are we talking about the physical conditions that we can't fix, that we can't correct? Lorazepam obviously can help calm the nervous system to help those jerking calm. And so that's why you'll usually see that easy combination. We'll talk more about medications. But we always want to prepare the family for the rough road. If we can have them ready for the rough road, and then we look like superheroes when it's the easy road, right? Like, this is what it could have been without me, but this is the way it was. So we just want to make sure that we prepare the families for that. From a psychological and emotional standpoint, right? We talked about fear of abandonment, right? Maybe my loved one won't be there, can't be there. And so as hospice, we try to help that. Fear of the dying process. Talked about COPD patients. And that, what is that going to feel like? You have somebody with pulmonary fibrosis. They haven't been able to breathe for 2 years, and those last few weeks are worse. And when you've had a bad few years and it just gets worse, that's hard. Fear of the unknown, and that could just be, I believe in something after, but I'm not sure, or I don't, and I don't know what's coming next. Is it just black? And then that withdrawal piece is challenging for the family, right? A lot of patients will withdraw into themselves towards the end. They don't want a lot of excitement around and things like that. So we want to make sure that that's where we start setting that stage, and we are aware of the culture that's around them. You're going to have families where there's 30 people in the room, right? And that's one of those families that you never go to alone. You always say, hey, chaplain, social worker, CNA, let's go handle this one together, because there's no way that one person can handle that many people. So we want to make sure that when we're setting those stages, and we know that there's a big family and there's going to be a big family around. I think we just had one with 9 kids in the room, 9 adult children, all of them doctors, lawyers. I forget who this was, but it was.
Oh my gosh.
There was a lot of firepower in that room, and the nurse handled it very well. But those types of things, we want to make sure that we have backup. And so we're setting that stage. What do we want for those children, those adult children, those grandkids, or vice versa? What do we want for those kids of the mom? And how are we going to set that stage? What music are we going to play? Sense in the room, things like that. So have you guys, from a social work chaplain team, have you guys come up with a end of life plan lately that you feel has been really effective and helpful? I didn't give them any warning, so we'll give them a few minutes to talk.
Go ahead, JD.
So I'm trying to come up with a good example. Nothing is standing out right now.
I don't think I haven't done anything like formal. Is that what you mean, like a formal assessment? I've talked about it with patients and families, which I think when they're in that place, it goes so much better.
Yeah.
When they're in that place where they can and will talk about it.
Yeah.
Sometimes what we would do is do a joint visit, Drew and I, where I'm kind of talking to the family about those final arrangement situations and also their emotions, and he's able to, do music and prayer with the family, which they always appreciate. Sometimes I'm bringing food and beverages for the family if there's a lot of people involved, so those are some of the different things that we kind of think of on their behalf.
Perfect. And that's where our facility partners can come into play too, right? If they're at home, maybe we bring everybody some milkshakes. But if they're in a facility, maybe we can have that little snack cart, especially if the family's going to hold vigil, or, you know, I always like to be fed when I'm holding vigil. But some juices, some snacks, some sandwiches. It's a little bit easier in skilled buildings because the kitchen's still open versus assisted livings when it's closed. Sometimes we need to go get some McDonald's or something. But those types of things, can we plan and help support the family as they hold vigil is important at that time too.
I've had a couple patients that I've had more time with and a lot of conversation with, and they're anxious about the end of life. So I've had conversations with them. You know, we've had great conversation, but when we get closer to the end, we may not be able to talk like we always do. What do you want me to do by your bedside when we can no longer have conversations?
Perfect.
And we talk about that in the earlier end when we can talk.
Perfect. So specifically, what as a discipline, as a chaplain, can I do for you when you can't tell me what you need?
Yes.
Perfect. And I think that's the same thing with social worker. That's the same thing with nursing. Same thing with CNAs. We just had a CNA last night at 11 midnight, something like that.
Yeah.
Because she specifically requested, hey, I want to be able to be the one that provides that last bath after they die. And so we had CNA and nurse out there taking care of them. And I love that our CNAs do that. I think that's unique. Any other thoughts on that kind of that last setting inside the room? I think that's where the life review comes into play, right? Some people want country music playing. Had one family that was a Hank Williams Senior fan, and so that a little twangy for me, but that's what they had, and it was going the whole time. Some of you are asking who Hank Williams is, and that's sad.
I think that remembering their cultural or religious background that might be different than yours and making sure the team knows that.
Yes.
Specific examples like one patient wanted the window open and she was set on that. So there was alert in the system for the patients that wear garments, making sure that those are on. And I think not touching the body, these are all things that like there needs to be a plan for in place prior.
Perfect. So we need to make sure we understand their cultural, spiritual background so that we can handle the body in a way that is respectful.
Those very specific things, yes,
Yeah.
that we need to be thinking about.
Perfect. And Brandon talked about when he was on the reservation, the Navajo reservation, like the body had to be moved outside before they took their last breath. So those types of things we got to know.
I was just gonna say, like asking family if they have an outfit that they want them dressed in, and I always like to talk to families ahead of time about like what the process is when they pass, because I think most families I think want to know like what happens when they die, just so that when they do pass, it's not this concern from the family like, okay, what's gonna happen now, what's gonna happen here, what do I have to do I have to do something? So saying this is what happens, we come, we do cares, we call the funeral home when you're ready, you have as much time as you need, you know, you don't need to come, do you want to come, having all those discussions ahead of time just I think sets the tone much better for the passing.
Makes me thankful for our veteran team too. We had a guy who passed this past month who was super excited, and I think it was comforting to know that our team was going to come and honor him after he passed.
Yeah.
And I think that it was cool to see, because it was the one who was the Korean War vet who said he'd never really felt honored. It was super meaningful to him and the family, and to know and to have some control or just foreknowledge of like that's going to happen after.
Yeah.
And that we can confirm that our Marines are going to come and honor you. That was cool to see. That kind of like that gave him peace, which was really cool because that's a meaningful part of his life that we could be like, this is going to happen.
Yeah. Perfect. Anything else from kind of that last setting the stage kind of perspective? I do. It's cool this how often we see in those notifications that we get, you know, dressed in their favorite outfit. I think we had one lady in leopard print at one point, some necklaces.
Some intense dressing that like over the years that I remember, like suit and tie, and Tiffany and I didn't know how to tie a tie. And we were usually in the room with him. I was like, thankfully the family's not here because we don't know what we're doing. Trying to tie. And I think like on call years ago, there was a tiny little lady, and the husband wanted her in this dress and in this big fur coat that they had for probably like 50 years. And she was just this tiny little lady, and we put her in this huge fur coat. But it was, I mean, those are good memories.
Yeah. So we talk about spiritual things like garments, and then things that mean a lot like fur coats. So yes, whatever's important to them, right? All right.
And I had a patient cremated with a box of wine. Because the daughter, that's all she would do. In the meadows, she literally every day she would drink her box wine, and that was her favorite thing. And we literally wrote an order that said, patient may have wine like whenever she wants, basically. And she was like, if she passes because she's drinking and she falls, that's what she wants. And so the daughter was like, we need someone with like her favorite box of wine, and they did. That was super important to the daughter. So you never know what you might.
You never know. Box of wine. All right.
Wow.
I wonder if, yeah. No. All right. So, see, this is why it's my favorite part, right?
Yeah.
This is why it's awesome.
I had a patient that demanded that she go out feet first.
The what?
She went out of her house feet first.
Okay.
So made sure that happened.
All right. So we get this question every day, right? All of us get it every day. Is my mom or dad going to starve? Are they going to be dehydrated? Is that going to be bad? So I just wanted to talk a little bit about some benefit to the things that everybody's scared of, right? So number one, enteral feedings do not reduce the risk of aspiration pneumonia or mortality. They are not, especially with something. So if you have ALS, a food keeping in a ventilator is going to keep you alive. That is abatement of the disease. But if you have cancer or Alzheimer's disease or something like that, a feeding tube's not going to help you stick around longer. And it'll probably cause some aspiration because that's what they do. There's 1, 2, 3, 4, 5 studies here that show that there is no evidence that increasing fluids decreases dry mouth towards the end of life. So there's, you can moisture and lick, and that's, that dry mouth, the dry mucus sometimes can be challenging. And that's why our CNAs pick up that daily visit, right? To make sure that oral hygiene's done. That's one of the biggest things there. So some of the pros of dehydration. So you increase production of ketones, which result in sleepiness and euphoria, and then cause decreased urine output. Decreased GI fluid resulting in decreased nausea, vomiting, and decreased abdominal distension. You see people as they near the end and aren't eating and drinking as much, their nausea goes away, right? The edematous layer around the tumor may shrink and pain may get better. Increased opioid peptide production resulting in increased euphoria and natural occurring analgesia. Decreased gastric stimulation will result in lack of hunger. So you're not going to feel hungry, right? And then the hypernatremia and uremia results in that clouding and sensorium, so that obtunded look, and then decreased lung secretions, which we all appreciate towards the end, that we're not dealing with a lot of that upper airway secretions. Those types of things are ways that, look, we get that they're not drinking more, but that's a good thing right now. We're not overloading the body with additional fluid. We'll take care of the dry mouth and things other ways, but these are all the benefit things that come from some dehydration. The body knows what it has to do as it prepares. We need to let it do that. Then the same thing with feedings, right? We can't feed up until the last day of life. I think probably the worst case of this, I had a patient literally die at the lunch table as they're on the feeding. They're part of the feeders, and they were being fed as they died.
Wow.
Okay, it was I was like, come on, guys. I am on a program timer thing here, and I'm trying to adjust it. Sorry if you're online and this is driving you nuts. So what we're trying to say my sincerest apologies. Okay, so hopefully you guys can see this okay. So frequency of symptoms in the last hour. What kind of symptoms are you guys dealing with that cause you troublesome and grief and try to manage with the families? What kind of things are you looking at?
Agitation.
Okay, agitation. What else?
Secretions.
Secretions, right?
Mhm.
That's probably the roughest one. Not for the patient necessarily, but for everybody that's trying to hold vigil around them, right? Pain. Is it surprising that only 51% of people have pain at the end of life? Not everybody needs to be on morphine 20 milligrams an hour for the last 2 days of life, right? It's kind of unnecessary. But sometimes it's needed, but pain generally isn't a pain, or death isn't a painful process naturally. It's the diseases that we have to deal with. That if they have chronic pain, we deal with that. If they have cancer, we deal with that. Agitation can be hard, especially somebody who is sitting up and laying down, getting up and moving. That can be hard for the family, because if they're there holding vigil, especially if they're in the home, then they're not getting any sleep either, and everybody gets worn out. And so we have to figure out how to manage that. Urinary continence, we have some simple solutions to that one. Dyspnea, we talked a little bit about that. And then the myoclonus. Does anybody have good communication on how we communicate two things? One, what's called the death rattle, so oral upper airway secretions. Does anybody have something that you feel is a good, and nurses, if you're out there nodding your head, you're welcome to come up to where they can hear you online. Good communication, good ways of saying what's going on. Do you have something that's kind of built in that you always use?
I typically tell them that the secretions are just resting in their back of their throat. And since their muscles are relaxing, they aren't able to cough it up, and that it's more bothersome for us than it is for the patient. It's not necessarily distressful for them. And then I go with repositioning techniques to kind of help decrease that sound.
Perfect. So the fluid's just sitting on top of the vocal cords, and when they breathe, it's there, right?
Mhm.
It's not that they're suffocating from it. It's
Not that they're getting pneumonia from it.
simple anatomy. And so that's why turning this guy over in the prone position was effective for the airway. That was the most concerning thing to the family. But when I provided postmortem cares, I can see why it could be troublesome. The face was bruised. You know, he had spent 5 hours in that position, but he didn't have that anymore. Talk to me about anticholinergic medicine for upper airway secretions. No, actually, talk to me in a minute about that. So, get ahead of myself. All right, so confusion, disorientation, delirium. If you have active delirium and agitation, that's very challenging. I told you about my Vietnam veteran he was obtunded. We were preparing for the last few minutes. He jumped up out of bed, got on top of the washing machine, and was swinging a broom. I didn't tell you about that? Okay, I've told somebody. Took the cops to get the guy off the,
Oh my gosh.
and then he died once we got him laid back down. So that's that last rush of endorphins can be to that extreme, or, hey, I'm good, I want a steak today, right? So never forget about that last.
I actually tell a story to a lot of my patients, you know, because when especially when the family's asking, you know, how long is it going to be, you know, whatever. And I always tell them the story that I took care of a patient that was totally comatose for 25 days. Woke up, wanted a steak, ate a steak, and the next day he passed.
Yep. So
that gives them that visual of what could happen.
yeah, we got the normals, right?
Yeah.
And we'll talk about some timelines here, but there's always those patients. The endurance runner that was
Right.
50 years old that lasted for 33 days with no further fluid. So that surge of energy, that sometimes can be really helpful for the families. They get that one last hurrah. And then there's some families like, oh, they're getting better. You know, so you got to balance that. This could be that last surge of energy and that last endorphin rush. So when we look at physical considerations, when somebody's dying and they have a fever, is there anything you can do about, does Tylenol necessarily help that fever? It's just different, right? People get that fever. When you're taking care of them and they're nearing that end, how would you describe their skin? Okay. Have you noticed that, you know, cold on the anterior side, sweaty and clammy on the dorsal side, right? Those things are very normal. Sometimes families are like, why is that? And then they'll cover them with a bunch of blankets like, well, hold on, they're warm under here.
Yeah.
So we got to help the family walk through that. Bowel changes. We want to make sure that the reason why we want to make sure people have bowel movements regularly is because we don't want that to be a problem the last few days of life.
I have run across a few times where people have had this bowel dumping syndrome right before they accidentally have them in 24 hours without giving them a bunch of medication. You know, they just, like, they've had the largest bowel movement ever, and I'm like, oh, it's coming.
So incontinence precedes the death and sometimes the dumping syndrome. Okay. Decreased intake, obviously, and then pain as it comes. Let's go to that slide. So we still want to talk about how do you identify somebody who's comatose that's in pain? What kind of things are CNAs? What are you guys looking at? Furrowed brow. Okay. That's number one on my list too. What else?
Changes in their breathing pattern.
Okay. Changing the breathing as you're providing care. Okay.
Sometimes when they have agitation. Part of it.
Agitation. Have you guys ever been just sick and you had to stay in bed for like a day, like 24 hours? Were you comfortable when you got up the next day?
No.
Right? You were sore as heck, right? Some of these patients been in bed for 7, 10, 14, 30, 5 years, whatever it is, right? Sore. So there's that piece that's there. There's the disease piece that's there. We just got to be able to identify it. And this is where I always ask the families, what is it? How can I know that your loved one's in pain? That's one of my first questions when I met somebody. How do I know if that's a problem? And so they're going to either tell you, well, they're never in pain, I don't know. Or they're going to say, you know, the facial features and things like that. And then I follow that up with, you know them better than I do. I need you to tell me when you think they're in pain, because we can do something about it. So there's the behavioral cues, and then roll out other causes. Which questions do we ask when 20 milligrams of morphine doesn't work?
Have they pooped?
Have they pooped and they peed, right? So we had, what was it? I don't think this, maybe it was with you. We had a patient where they had gotten 40 milligrams of morphine. It was like 2 hours later and it just wasn't working. And then we threw a catheter in and yeah, can't pass with a full bladder. It's impossible. You can't sit in a car with a full bladder. You can't die with a full bladder. Just.
No. Recently, who was close to passing, and his pain was like so extreme. You just touched his pinky, and he was crying.
crying out in pain. And to me, it wasn't physical pain. He had a pretty traumatic past. He's a veteran and had a pretty traumatic past. And we thought that he was maybe reliving those things closer to the end of life. So the pain medication wasn't necessarily helping. It was the other medication to help him be able to relax. But it was extreme.
I'm glad you brought that up. So two things could be going on. One could be that traumatic past that any physical input creates psychosis, right? The other piece is if you're giving somebody, let's say morphine, and you're like, this should work. And you've rolled out everything else. You've rolled out bowel obstruction. You've rolled out constipation. You've rolled out urinary retention. And that's all good. But they're getting this morphine, and a well-intending family is giving them maybe more than you would if you were there assessing 24 hours a day, right? And you walk in and you touch their skin and they jump at that touch. They're toxic on that morphine. That's very, not common, but that hypersensitivity is what happens when you get too much morphine on board. And so you either need to stop, which is like, that's hard for families, right? Well, they're uncomfortable. Well, they're not uncomfortable because of morphine, because they got plenty in them.
Can you switch the medication?
Okay, so opioid transition.
Like maybe change it to oxy, does that do the same thing?
Yeah, so oxy liquid or dilaudid liquid.
They don't have that hypersensitivity effect?
If switching the opioid will reduce that. Yeah, so you gotta do an opioid switch if that happens, or try to back them off. If they're not right near the end of life, then try to back that down.
And you switched him to dilaudid and fentanyl.
And that helped.
And
Okay, so switched into a fentanyl patch and dilaudid, calm that down. We got confirmation.
yeah.
Okay. Cool. So that's the big thing, right? Switching that pain medicine at the end of life, that touch. So if you touch their arm and it's been broken and there's lots of pain and they're reactive to that, that's one thing. But if there's no injury and they're reactive to that touch, you got to change something. Thank you for bringing that up. Speaking of opioids, so we talked before about families giving that last dose of morphine, right? There's always going to be a last dose of something if we're treating them routinely. It's not uncommon for people to die with no medicine on board, right? Death is a natural process. The body knows what it needs to do. But if we're dosing people with medications, there's always going to be that last dose of Ativan or that last dose of morphine that then they pass away. And that's another piece of that education thing, is like, you didn't do that, right? They didn't die because of you. That CNA that I talked about last week at the nursing home, that was her first death. Her thought was, well, I moved her and he died. Well, you didn't kill him, right? Just changing pressures in the body finally stopped the heart. But it's easy for families specifically, or our younger healthcare workers, to bring that on themselves and say, I killed them. When you talk about, let's talk about half-lives. So what is the half-life of morphine in a normal functioning body? 4 to 6 hours. Thank you, recent graduate.
You just told me that.
Oh, okay.
2 days ago.
Don't worry, nurse practitioner graduate, I got you some questions too. Okay, so morphine is 4 to 6 hour half-life, right? How often do we get requests for or need of morphine 20 milligrams Q hour? Every day, probably, right? There's a reason why our comfort kit is every 4 hours as needed, because there's an understanding of medication pharmacodynamics, right? What is the half-life of Ativan? 4 to 6 hours. Half-life of Haldol. Sometimes 12. And the right person, you can get 24 hours out of Haldol, but generally 8-ish hours. So when we request a dose or order a dose of of morphine, let's just say morphine, 20 milligrams every hour scheduled. What are we actually giving them? 4 hours later, what is in their body? 80 milligrams of morphine is running around their body. Now, how is morphine secreted? How do you get morphine out of your body?
They're shouting out the answer.
They are. I'm just looking at you. You're in the master's program. So morphine is excreted through the kidneys. If your kidney function is in the tank, because you clearly see brown, black, tea-colored urine, right? Their kidneys aren't working, right? They're not hydrated. Now, how long is that morphine lasting?
Probably double or triple.
8, 12, something like that. So let's take that Q1 hour, 20 milligram morphine and take that out 10 hours. How much morphine do they have running around in their body? 200 milligrams of morphine. If you can't get a patient comfortable with 200 milligrams of morphine, something else is going on, right? So we want to make sure that we're doing that smartly. What are we actually doing? Sometimes it can just, sometimes my bladder is just full, right? Morphine is never going to relieve your bladder, I promise. It will tighten that sphincter up and it will not let go, right? Right? That's a side effect of morphine, yes? Bladder retention? Okay.
I was just gonna say, I had one on call that I went into the house and couldn't get it comfortable, checked all the main things and everything, and I had 80 milligrams of morphine. I can't remember how much Haldol, how much Lorazepam, and nothing. And finally, I thought to myself, what's going on here? And I talked to the husband. I said, you know, the whole family is there, and I'm like, is there any way maybe we can maybe lighten the load in here and take some people out so it's quieter for, you know, fan on face, do that kind of thing. And he says, well, that's maybe an idea. She hasn't seen these people in 20 years because she was ostracized by them and everything. Oh man. So we kicked everybody out. 15 minutes later, she was asleep.
Okay.
And she stayed that way. And it was completely the environment she was in and the people that were around her that was keeping her just totally agitated.
Beautiful. So we did all the normal stuff and then switched to just looking around the environment. Anybody know why we know who Florence Nightingale is? Why?
Because it took 2 hours for her to run up and down the hall, which is why you're supposed to turn everybody every 2 hours. Just wanted to throw that out there.
Okay.
No evidence-based practice on that.
So I actually didn't know that. So
Yeah,
Florence
it's fun.
Nightingale, it took her 2 hours to go up the hall. So that's why we implemented Q2 hour
Yeah.
turning schedule.
Yes, I did a whole thing on that and researched and tried to find good sources. So
That's-
there's actually no evidence-based practice.
That is awesome. So when was she doing that?
Oh, and what was it?
What was going on when Florence Nightingale made a name for herself?
Oh, there was, like a battle and a lot of people.
The Crimean War,
Oh,
right? So in the Crimean War, what was going on in the late 1800s? How did we treat sepsis in the Civil War?
cut them off.
Cut a leg off, right?
Yep.
So battle injuries were going on. And when she looked around the environment, she saw bloody clothes, dirty water, stale air, infection everywhere. It stunk because we're in an enclosed hospital. And so what'd she do?
Open window, run.
She opened the windows. She got clean linens, which was surprising, right? She made sure that the physicians were doing surgeries with clean towels and cleaning the supplies. And she was doing all this environmental stuff. Guess what happened?
Infection rate.
Infection rates went down, mortality went down. Patients had a better quality of life in the middle of a war zone. And so, you know, sometimes in a family with 50 people around the room, it may feel like a war zone a little bit, depending on where they're at. But we can still take that environmental look, like looking around, what is agitating this person? Gary's point, this person was somewhat ostracized by the family, and now everybody was showing up Is this the same one CJ had?
Yes.
Okay, so family was also, while she was dying on the table, hey, why don't you take the TV? I'll get the radio,
Oh my
right?
gosh.
Who wants those people around? So that's where Gary could shuffle people out, and then she was able to be.
I was gonna say, one thing that I added to my practice from that experience was now when I'm doing admissions or when people are getting close, I recommend a period of time that they actually just leave the patient alone. You know, give them 15, 20 minutes to a half hour where no one's there because, you know, and also I noticed that some people won't pass until they're by themselves.
Yeah.
And so I added that to my practice that occasionally, you know, you need to leave these people by themselves and let them be alone.
And we can take that to a hospital setting, right? Or a skilled nursing setting or an assisted living facility setting. So if you're not controlling the environment, that body is getting too much stimulus, right? I don't know if they, so when I was a CNA, we had this light above the bed, and you clicked once, it shined up, you clicked twice, it shined down, and it was like a blinding light. So in my patients, I unscrewed that one because it was terrible.
I've done that too. I thought I was the only one.
You got to do it, right?
Yeah.
Because you have this well-intentioned person that has all these patients they have to take care of in the morning, and they run in, they flip on the light, and they're like, gotta go. And so you have that light stimulus plus the staff member that may be rushed. In the hospital, you got all this beeping going on. So trying to find, at Madigan, we were able to isolate a room in the Army hospital that was away from the nurse's station. It was away from all the beeping. It was away from the call lights. And it was pretty quiet back in that room. And we were able to create our palliative care room back there. And we had brought in some couches and some sleepers and stuff for family to sleep on. So we were able to move them away from the chaos that is a medical surgical oncology floor, right? Same thing in a nursing home. Can you decrease the environment stimulus? So just like no amount of morphine is going to overcome a full bladder, no amount of morphine is going to overcome the stimulus that's going on. Well, maybe enough, but we can get by with less medication if we can control the environment. How can medications be administered? Anywhere there's absorption tract, right? So if you need to do orally, rectally, I think in another class we talked about vaginally with a tampon if necessary. The 80% less effective, but still effective. Our pharmacy finally ordered that the soft set needle for the stomach. When we do the pumps, the morphine pumps, it used to be the metal needle stayed in. And I was like, that just didn't make any sense. So now they have one where the metal needle comes out and it leaves a plastic catheter in, so it causes less irritation. So that's cool.
Last ones I use, it was still the metal.
Yeah, they got the new one now. I specifically asked for it. So if you're not asking for a soft set, make sure you do. All right. Okay, we'll go on. So accumulation of metabolites. When you have too much morphine, which we just kind of beat that horse to death, right? You get myoclonus, you got seizures. So when you have the morphine being processed throughout the body, the metabolites left of that morphine cause issues. We have to be cognizant that our well-meaning intentions can cause more problems toward the end of life if we're not dosing that pain medicine right. Same thing goes with Haldol. So when you look at myoclonus specifically, the two big offenders are antipsychotics and morphine at the end of life. Benzodiazepines can calm the system enough to where you don't have a lot of those. And so that's sometimes where you see that that combination, that role of the medications to try to help alleviate those. And then not only from medications, but they can come from cerebral edema. Edema, thank you. Hypoxia. So if you know somebody is COPD patient, pulmonary fibrosis patient, those issues can cause tics, myoclonus. Multi-organ system failure. renal failure, hepatic failure, liver cancer, almost always are going to happen. So we need to make sure that we can manage those. How far are we in this? 1 hour? Okay. So benzodiazepines, what benzodiazepines do we sometimes use in hospice? Ativan's one, right? Comes liquid. Xanax is another one in a pill form. Might have used diazepam for seizure abatement. And then sometimes we might use clonazepam as an augment to their delirium or psychotic features. It may also be an anti-seizure medication. What are the half-lives of those medications? What's the half-life of Xanax? Lorazepam, we said 4 to 6 hours. So Xanax, 2 to 4? You guess 2 to 4? 2 to 4, good guess. How about diazepam? 6 to 8. And then clonazepam, 8 to 12. So when you look at the pharmacokinetics of benzodiazepines, how do they sit in the system? Where do they, I'll stop picking on you, Cody.
Yeah, listen.
So how do they sit in the system? Where do the metabolites go after you try to clear them? Sits in the adipose tissue, right? So when you build up enough benzos, then you have it sitting in the adipose tissue, and then it starts causing problems that way. That's why Ativan is one of the biggest causes of delirium and hospitalizations, is that long-lasting effect. We talked about switching opioids already, and the end stage, if we're not noticing what's going on, that can lead to seizures and other kind of problems. If you had to guess, how many people in studies, percentage-wise, have intractable pain at the end of life? Pain that just cannot be managed.
1 out of 10.
1 out of 10? Okay. Any other guesses? 5%? 7. All right, we're in between. All right, so the studies, there's 3 of them here that show that right around 16% of people in a palliative care hospitalization setting have intractable pain to the point where they have to go to palliative sedation. And so there are times, right? 1 in 10 of our patients or 2 in 10 of our patients might have intractable pain that we need to manage other ways. And that will come with a mix, but sometimes a different mix, right? So you've heard the term palliative sedation. What does that mean? What does palliative sedation mean?
Palliative sedation?
Palliative sedation.
We're in the place in order to keep them comfortable, that we have to medicate them.
Okay.
And it happens with dementia too. I feel like in the younger patients, when they have that outburst of they're throwing everything, or throwing chairs, or on top of everything, and you have to just medicate them.
So it could be delirium, right?
So they're comfortable.
Versus just pain.
We're past the point of trying to figure out really why this is happening. We have to use medications to keep them comfortable.
And you've had some rodeos in your career,
Yeah.
with some young guys with Lewy body or frontal temporal.
Yeah.
Which one is?
Ray Flashbark, the one.
We're recording, so no names.
Yeah, he just had Alzheimer's, but he was like 65, and he was getting on top of the tables in the OIE and throwing everything, and was so uncomfortable, and we just had to medicate him.
Yeah. And there'll be that terminal agitation, delirium, and I know sometimes the hospice nurse will call and say, like, I think this is terminal agitation, and we're just not getting in front of it. And so we'll adjust our focus from calming the best we can to, okay, let's get a little bit more aggressive if we need to.
Catherine and I had a COPD patient that was that way.
Okay.
We literally had to get him sedated, and we were using everything every hour, and I think it lasted for about 4 hours.
Because of dyspnea, or
Yeah.
just
He
couldn't
was-
breathe.
he was- Just couldn't breathe, and he was just fighting like nobody's business.
Yeah. So there's shortness of breath, there's delirium, and then there's pain, intractable pain. All right. So Okay, Chaplain Jack. You guys remember Chaplain Jack from last week? His wife, we got to take care of her while she was on hospice. She was a breast cancer survivor. I think it was it 7 years? She fought it for a while. And she was one where we could not get in front of the pain. It was just, we were there almost 24/7 trying to get in front of her pain. And when we finally got there, there was a significant dose of Dilaudid running through her body. And we finally got to the point where she was comfortable and somewhat comatose, a ton did, right? And so Chaplain Jack and his wife, they were both ministers. And so they adopted a kid when he was like 16 or 17, just, he was stealing stuff, doing drugs, just one of those kids that probably wouldn't have lived until he was 20. And so they adopted him and they brought him in. I can't remember how it came to be, but this kid, 15 years later, early 30s, had a family, a couple of kids of his own, good job, because these two people brought him in. And so probably one of the coolest moments at the end of life, he's at her bedside, and saying his goodbyes and tearful. And this woman who had been kind of bedbound and not moving for at least a day, she put her arm up on his shoulder and patted his back, and you could kind of hear her whisper, "It's okay." And then put it, that's so cool. Just an amazing lady. But we had kind of had to move to a palliative sedation point for her. We just couldn't get her pain under control any other way. When we picked her up, she was on 300 micrograms of fentanyl from the oncologist, plus 60 milligrams of oxycodone every 4 hours as needed. Just a ton she just had a lot of pain. She was like 80 pounds. And so the pain had the cancer had gone from breast to bone, and it was just rough. So we use palliative sedation for her. So the easy ways that we can do that in our setting would be oral, right? Liquid morphine, Ativan, Haldol in the right mix. We may use sub-Q morphine if we have access to a pump. When we get people discharged from the hospital and they have a PICC line in, the baseline answer is leave the PICC line in, right? We want that. If you needed it, I'm probably going to need it. So leave it in, and we'll manage it. We'll flush it. We'll keep it working until we do or don't need it. It's especially if they're cancer, if we have access to their port or a PICC line, we can do a more effective job. We can't keep peripheral lines in the home, right? It's just dehydration. It's just not going to work. We're going to be up and down. So Lorazepam, ketamine's on this list. Obviously that's going to be more of a hospital setting. I used it once outpatient. We did ketamine, and it was on a Vietnam vet, and he had done a lot of fun drugs in his life. And so when he woke up from that, he's like, that was the worst trip I've ever been on, man. But his pain was gone. It was like a reset button. It was really cool. But I haven't used it since then.
Yeah, I can call it real bad hallucinations. Right?
Yeah, bad hallucinations. So you got to give it with the right dose of benzos.
Vibrant, like.
Yeah. So ketamine with some Versed, maybe you're good, right?
Mm-hmm.
That's a little hard to do in the home setting.
Yeah.
And you're definitely not going to get an assisted living to let you do it. All right. So how do we prepare families for that imminent death? What kind of things, what kind of signs are we looking for, right? We got it spelled out in the back of our admission book, but how often are we referring to that book, and how often are we just going off our brain? And when we're going off our brain, what are we teaching families? So what are we teaching families that last week of life? What are we looking for?
Increased sleeping.
So increased sleepiness,
Intake.
decreased intake, decreased urine output. Okay.
Decreased responsiveness.
Okay. What would you say is the timing, a rough timing of, let's say, decreased intake? How long before they pass away are they going to eat less, drink less? Last week or two? Okay. Okay. For some, it may be forever, but in general, you may see a decreased intake the last week or two of life. Okay. What else? When do you start to see, let's go to urine output. When do you start to see urine output decrease? Last 72 hours. Okay, good. So, and then when do you start seeing modeling come on? Sometimes never. Okay.
Yeah, usually within 24 to 72 hours.
24 to 72 hours.
That's when
Okay.
I really noticed it.
Okay. So definitely that last day or two. And then how about respiratory issues? What's that?
Breathing changes, I feel like, are like the final thing, when you start having the Shane Stokes irregular between the little guppy breaths and then apnea and then some of the deep breaths.
And what did you say is the Medicare approved term?
Shane Stokes breathing.
Chain stoking. So I don't know if you guys know, when our charts get audited, it's not by a nurse or a doctor or a social worker or a chaplain, right? It's by an administrative professional that is looking for terms. One of those terms is chain stoking. Also, one of those terms is doing well, life review. So chain stoke breathing, and I don't know if we could hear you. What does chain stoke look like?
It's the patterns of the breathing change between being the short little guppy breaths and then pausing between breathing and then maybe some deep breaths. There's no regular pattern.
Right. But if you had to pick a pattern, it would be that deep breath.
Yeah.
Down, deep breath.
Ladder stepping.
How long of pauses are we preparing our family for?
90 seconds, yeah.
Okay. So a long time, right? So it could be 10 seconds, 15 seconds, 30 seconds. I told you about my first actual death, right? That I was at. Like, guy didn't breathe for I swear it was 3 minutes, but it was probably like 60 seconds. But I was like, oh, I think he's gone. So I put my stethoscope on the heart and he took a huge breath. I hope the family didn't see what was on the inside, because I jumped. So we want to make sure that we prepare the families for that breath and that lack of those pauses. Yeah.
I look for respiratory compensation.
Okay.
When the heart rate comes up and the breathing comes up, and then talk to them about when they're really close that they'll stop trying to compensate.
Oh, so we're getting real technical. Okay. So heart rate, what's your heart rate? So if we're talking about, just in case they couldn't hear you on the video. So talking about respiratory and cardiac compensation for the dying process. And I have a number in mind for a heart rate for me. Which yours is 110?
When they're close to passing?
Yeah.
140.
140, 140, 120, 130?
The 90 people in 90s can't do 140.
Maybe.
Yeah, 130.
Yeah, they can. Yeah, they can.
So my mind, so Gary's is 110. My mind has always been right around 140. But so what I'll talk about, and maybe you do the same, is you see that heart rate go up, that's the body compensating. And then as that heart rate comes back down, that's the body not able to compensate anymore. And then we'll see that trend down. And that's
exactly what I'm saying.
Perfect.
And usually 110 is when I think it's starting, and then I tell them it can creep up from there. And then I tell them, well, you're gonna hit a split point at that point where either the heart's just gonna say, okay, I'm done, and just stop, or they'll do that trend down.
So I would encourage caution with families, because I've had families that I've had that same conversation on, and there is a pulse ox on their finger 24 hours a day looking for that number. So, some people want a lot of information, some people don't.
Well, and I usually say that those numbers come along with the nursing assessment, because they're like, well, can we track it all the time? I said, there's more to it than just those numbers. I'm just using those numbers to illustrate what I'm seeing.
Okay, good.
I typically don't tell my family members numbers. I just tell, you know, your heart rate, his heart rate's gonna go up. Sometimes his blood pressure is gonna drop, but those numbers will tell us where he's at in his process.
Yeah, cool. All right, so we got chain stoke, we got heart rate compensation, probably some intercostal muscle use for breathing, right? When you look at the respiratory secretions or death rattle, what's the interventions? What's your number one intervention?
Repositioning.
Repositioning, right? What is, research-wise, what is the benefit of atropine, scopolamine, hyoscyamin to dry up the upper airway secretions?
It's supposed to.
It's supposed to.
Does it work?
I'm telling you.
There is zero, like not a little bit, there is zero report that in studies that those help. So why do we use them sometimes?
Because it gives the family,
Because the family needs to know we're trying to do something, right?
or they're trying to do something.
Or we allow them to do something to try to fix the problem.
Or facility demand.
Or
Yeah.
facility feels like they need to do something, right? They have a commitment to this family and they need to be able to work through that the same way that we do or the family does, right? So even though there's no benefit to it, you're not going to overdose somebody on it, right? So there's really not a terrible downside to it. I mean, we might use a scopolamine patch for nausea in a cancer patient, especially with head and neck cancer. But at the end of life, there's really no use for that. And so we use atropine drops or hyoscyamin tablets. We don't use them a lot just because there's not a medical reason for it. The number one thing you can do is what Brittany said, is reposition. So we've hit off and on about flash pulmonary edema. That's where that just comes on and hits it. And other times it builds up, right? And so what positioning are you going to do? So we got urine output, 3 to 4 days out. We got cold and model extremities that last 24, 48 hours, sometimes less, sometimes never. We got the heart rate, vital sign changes. We got the chain stoking. And then we got to come up with a solution for the death rattle. How do we position? Head elevated one.
On one of their sides.
And on a side. Which side do you pick?
Last.
Okay. So
Yeah.
So I usually try to pick left. And there's some mechanical reasons for that, right? There's more mass on the right side of the lungs that is pushing onto the heart that maybe they don't have to go through that as long. There's benefits to both, but it is whichever one the patient works, right? You can have patients at 90 degrees on a side. The gentleman that I was with, the final position I was able to find for him, head of bed was about 15 degrees. He was kind of in the fetal position and we had him propped up on pillows on the anterior side. So his shoulder was behind him and he was forward. And that was the only way we could get no fluid on his airway. The challenge that came with that was a lot of edema and mottling on the right side of his face, but the family didn't see that. They didn't see it ever. Good job, me. So if you got to do that, and there will be times that you have to, right? There will be times that an anterior position, a prone position might be the only way that you get a clear airway. There's going to be a lot of facial edema. So you just got to be aware of that and maybe even prep the family for it. Hey, if we get him in this position and the airway's better, you just got to know he's going to get some swelling on his face and we'll deal with it. And there's always makeup at the funeral home. Those are things to do.
Something that also brings comfort to the families is the normalization of it. Talking about how normal it is, it's not something that's out of the norm. And families seem to, okay, so it's not a bad thing if this is happening. And they don't freak out as much. At least that's what I found when I normalized it to the families.
Yeah.
It prepared them and they weren't freaked out when they heard the rattle.
To the best we can normalize, right? And if we've used that term beforehand, they're like, oh, okay, this is what's happening. Or they can call you and say, hey, this is on our home patients, right? We visit towards the last 7 days, 2 or 3 of us are in the home at any given time, right? Or any given day. So I went through this education with my brothers. The last week of my mom's life, I was like, okay, if we're looking for this, let's do this, this, and this. And when this happens, you need to call hospice so they can come out and look. So when I was texting my brother that last day and I was like, hey, how's things going? He's like, oh, our breathing's a little bit different. And that's where I was like, oh, he hasn't said that before. So that's where I got on the plane and I flew down. They still hadn't called hospice. She was in full-blown pulmonary edema, the worst death rattle I've ever heard. My brother's in the other room with headphones on. That's the emotional brother. The logical brother was in the room looking through paperwork, trying to avoid what was going on. And I walk in, I was like, what are we doing? Where's hospice? Like, well, we didn't think to call them. So I say that because we have to teach our families when to call. Mm-hmm. And any of these things, decreased urine output, modeling, respiratory changes, we have to teach our families how to call, and we have to teach it to them every day. Because I know I told my brother just the day before, if this changes, you need to call hospice so they can come out. And he didn't do it. So we need to make sure that we're telling people every time. All right, any questions on that last kind of body preparation changes? From a CNA perspective for you guys, what are things that you guys do that last day, those last couple days? What things do you guys like to do? I know it in my head, but I don't know if you know you're doing it.
I always just make them look like how they look like before.
Okay.
I always fix their hair and put their makeup on like how they normally do, because that's what they like.
Okay.
And reposition them and to make them look presentable for the family.
Perfect.
I freshen them up and make them feel better. You know, I want them to be able to, like cool the body down and just be comfortable. And again, do their hair and makeup.
Perfect.
Change their
sheets.
Change your sheets.
So they have clean sheets.
Perfect. Change the pillowcases.
Pillowcases, everything gets changed. I had one yesterday and I was checking with family members that were there. What do you need to see? What do I need to do to make this easier for you? Because at that point, it's more about them.
Mm-hmm.
And sometimes they'll show us, they'll have a picture there and they'll say, can you maybe do a little bit of that? Sure, I can try. And we do that. That, can you fix your hair like that? Well, sure, we can try that.
I always have their outfit set out for what they want.
Okay.
And usually put a little note on it for them.
Okay.
For the facilities if I'm not there.
So one of the things I've heard at the company meeting, we were talking about A and B team players, right? So what I've always heard from the CNAs is our people look better than if they're in a facility, they look better than anybody else in the facility, right? That's kind of your standard.
Mm-hmm.
And we've seen people who haven't set that standard who have been asked to leave because that's not the person they are, right? And so I love that as a team, you guys set that standard, and I hope that you guys always keep that.
Yeah.
I saw Casey back here like nodding emphatically.
Sometimes I don't know the people when I go in to see the facility, but I can always narrow it down. I can tell who our patients are, and then I can try to pick them out from there.
Right. Nails are done. Hair's done. Yep.
I had a lady who got a little confused yesterday, thought I was a hairdresser.
Yeah.
Really mad at me. I had to leave because she was getting so mad she almost hit me. But she was like, brush my hair. I was like, look, her hair looked great. They had just curled it. So it was kind of cool to be able to say, actually, you look great. I kind of tried to show her, but she was deep in it. She was really mad at me, but it was kind of cool. I was like, actually, you look wonderful. Like, you don't need to, I'm going to make it worse. I'm going to undo whatever. I'm going to undo it. It was kind of cool. When you said that, I was like, actually, I feel like often I'm walking up like, oh, patients look great.
Good. All right. Let's see. So we talked about death vigil. I love the one where we had a patient here at a facility, and the husband was in Florida. And I don't even think there was a question on the shifts. You guys just volunteered for the shift, so she didn't die alone, right?
Yeah.
All the way down. I'm going to say all the way down to our marketers. But it was just cool to see all that. One of the things we want to make sure with our families is that they know what. So I'll flip the book open to that page and say, these are what I'm looking for when I'm here. I want you guys to call me when you see anything. If we still got 2 or 3 days left, I want to know all these things. I want to know when you see them so I can be here if you need me. Or we can have our on-call team come out or something like that.
I'd like to give them that one death is near booklet too.
Perfect.
That back there, it like breaks it down.
Perfect. So we have 2 resources, When Death is Near pamphlet, right? And then the other one, similar wording in our admission packet. Death is Near is easier to kind of, this is what we're doing right now, right? And sometimes it,
Who like got comfort in doing the checklist on that book.
oh, really?
Yeah.
So her way of processing it was
Yeah, it was
check,
so
check.
fun, but like the way is like how some people are like list makers.
Was he an accountant? Guarantee he was an
No,
accountant.
geologist.
Close enough.
Yeah, but I went back in the next morning and he had just been checking it off and crossing it, and you could just totally see that. And I was like, all right, I'm gonna have to grab more of these books because that gave him something to do.
Cool. So we want to, we're going to work through the painful piece, make sure that we can make them as comfortable as we can. I mean, every day we're asked, how long do we have, right? The interesting ones I find is the patient has been on hospice for 6 months or something, right? And not a lot of changes. And then they finally make that kind of terminal decline. And I know this is going to happen with your patient, or it did when I went out last week, is that when the family finally recognizes that I know I've been on hospice for a long time, but that actually means that my mom is dying. That is so hard. It's easier if they come out of the hospital and we got 7 or 10 days with them, like the family they're in go mode already. But when you come on hospice, you're kind of in that go mode, and then things kind of smooth out. Hospice makes things a little bit better. The pain's better managed. The symptoms are better managed, and everybody relaxes and they're like, okay, we're okay. And then that decline happens, and then they got to get themselves back into go mode. That's really hard for some families. So when they're asking timing of death, we want to do our best to provide our best guess. Every time when families ask me that's always proceeded with, I know you don't have a crystal ball, but how long do we have? And so I think some of us has gotten pretty good at that based on, my thing is urinary output, right? When I see that there's only 1 or 2 urines a day and it's darkened and tea colored, that's when I can confidently say we got 4 or 5 days left, maybe less. And then we kind of back in from that on those symptoms. So if I could, I got 4 of our chaplains here back there. So maybe let's just real quick touch on death rights. The things on the top of your mind when maybe let's go down religious affiliation. So Catholicism, what kind of things are we doing? If somebody wouldn't mind coming up closer. JD was voluntold.
So popular terminology would say last rites, but I know that the church wants to get in before the very, very end and to anoint the sick.
Okay.
And so I know that at least one of the churches in town said, if we get in and they're still alive in 6 months from now, we'll just do it again.
Okay.
So they want to avoid the priests being rushed out as soon as or late, like the very, very end. So our standard is once they come on to our service and they're Roman Catholic, we make that call right away.
Okay.
To get them in there.
Okay. How about Jewish? You might as well just stay put.
Well, I know that one of you guys just worked with a rabbi. I know that one of you guys were pretty close with one. So I think you.
Oh, that's right.
Okay, so let's go to Islam.
Thanks for volunteering.
Come on up, Tim.
Pretty much situation with that was just making the effort to contact Mijat, the imam. Very busy man, 200 families in the valley he's looking out for. Hard to get a hold of him. But then, okay, so we have this patient, and please tell me how it is that we have to look at these last hours before death, and then at death, who's there, and then after death, 1, 2, 3. So kind of try to move through that with him, take some notes, and then inform the team and get it in the alerts.
Can you tell me what those are for our information?
Well, at the time, COVID was really tight, and so the imam was not able to get in. But if he was, he would want to be in there and offer some prayers, that kind of thing. There's also a gender issue depending on the patient.
Mhm.
And so we kind of have to be careful with that as well.
But I think depending on orthodoxy, right?
Right, exactly.
But in general, we should assume that
Yeah,
a female patient should be cared for by female
that's
caregivers
default if possible.
Yeah.
Yeah, at all possible.
and male.
Yeah.
Okay.
And so then there's that piece. And then at the moment of death, if he's able to be present, that is good.
The
and-
imam?
Yeah,
Okay.
if possible.
He wants to be there if he can.
Yeah,
Okay.
he wasn't vaccinated, so wasn't able to go in, that kind of thing. But, and then afterwards, and just depending on the Orthodox, like you say, that's where you got to get it from him as to who's in the room and how the body is treated. And then even with like our Orthodox Jews, it's like, what do we do? How do we get the body, to the mortuary and that kind of thing? And it's just so dialed into the family and the rabbi
Sure.
or the imam.
In general, though, from an Islamic standpoint, there needs to be a fairly rapid burial.
That would be the preferred thing. Now, in Western society, there's been a lot of accommodations, even with Buddhism and Hinduism, just the idea of what do we do in the Western world since we can't get the body in the ground in 24 hours. And then when you get like on the weekend, you coming towards the Sabbath with our Jewish folks, oh boy, make sure you're in tune with what's going on there, because there can be some real strict observations with the Orthodox on that.
And so while you're sitting here, let's talk about, so from a Islamic standpoint, caregivers we need to default to male and female, right?
Yeah.
Make sure that the imam's involved.
Yeah.
And then we should plan on a fairly rapid, as quickly as we can, from death to burial.
Yeah, if that's possible.
Okay.
Yeah.
And so we need to make sure that we have I would assume there's a funeral home or two that's used to working with that community.
Yeah.
Okay.
Yeah, I don't have any particular named ones, but.
Okay. So from a Jewish standpoint, definitely the rabbi's involved.
Yeah.
And there is something specific with the bodies never left alone.
There can be that as well.
Okay.
You go from the strict Orthodox all the way to the Reformed. And so it really does, you really need to be in tune with the family. And even sometimes if they're not really close with the rabbi, their family precedents can actually kind of be more important than what the rabbi, so that's a balancing act,
So if we're going to go with strict Orthodox observance, how would we treat that person, that body from, let's say, from time of death?
That's going to be, again, a gender issue there too, as much as possible.
Okay.
And I'm just reading up again on this the other day. There's just been a few changes in Western societies with the Orthodox, but they're going to take the cares. The males are going to take the cares.
They're going to do the cares and stay with the body, right?
Yeah, yeah.
And that may be, if it's not a funeral home that's used to that, that might be weird.
Yeah.
Right.
Yeah, for sure. And so we're trying to make that happen as much as possible. I look at my role as getting the information from family, from the rabbi, or those stakeholders, and then saying to the team, really kind of tune on this. This is out of the ordinary, but let's do this for them.
Okay.
And do the best that we can.
Okay.
And know that, especially on the Jewish side, that there can be some real idiosyncrasies even within Orthodoxy, within Reform, within.
Sure. Okay.
Yeah, with some of the Orthodox Jewish patients, they don't want us to touch the body as soon as they pass.
Thank you. So there's, we can't touch the body after.
Correct.
Okay.
And so we had one patient in particular that didn't want their loved one to be touched after the person passed until the funeral home got there. And that particular funeral home was more familiar with Jewish practices on how to take care of the body postmortem.
So that would be something that we want to make sure that we plan ahead of time.
Yeah.
Because our loving CNAs might want to be there, right?
I want to say something on that.
Yeah, so we had alerts in the system, and Brittany was the nurse on that one, and when the patient was getting close, she would put that in the email, in her on-call email every night to make sure everybody knew.
And I had the facility admin also email the staff out and let them know, because if she was touched by anyone other than the person from the church doing the ritual, she could not be buried in the Jewish cemetery.
Yeah.
So it's very, very important.
So I had a patient that was Jewish, and they had to, I don't know who it is, but they come in, they put them in this certain outfit before they die, and they have to play a certain prayer. And then they have to be there for so long, and they have to pray like every single day. And then they leave their body there. I think it's like 24 hours, or something like that afterwards.
Yeah, so those are depending upon the religious background and how strong it is, whether it's more Reformed or Orthodox. We try and field a lot of those questions with the family, and for some of them it's not as big a deal, and for some of them it's very, very important. So we try and work through that on the front end when the patient is admitted to our service, so we know what plan we have to have in place and who to communicate with.
Perfect.
So that's one of the first things we're doing, is we're getting permission from the patient and the family to contact that tradition, that clergy, so that way we can all be on the same page.
Sometimes those terminologies overlap. Callie called me the other day with a patient who were like, "Hey, has this patient gotten last rites?" I was like, she's not Catholic to my knowledge. The family just wanted a prayer.
Sure.
So some of that is feeling out, what do they need in that moment? What are they asking? And I was like, so what is it you guys would like? And they just wanted a simple prayer. They weren't necessarily religious, and their mom hadn't been, but she had been when she was younger. So it was more of just they wanted the comfort of that.
Sure.
So I was kind of feeling that out though, because it's like, I was like, has she been Catholic this whole time? The family didn't tell me.
Well, that's how they worded it, and I was
you know?
like, yeah, well, that's what they said.
Yeah,
So
right.
I
Some of that
said it.
terminology can be confusing, or sometimes, like for her, I sang religious songs that she remembered from her childhood, and especially as a memory care patient, that was really meaningful to her.
Yeah.
I may not have expected that with her not being religious, and so sometimes there's that like, what was her religion when she was younger? What is it now?
Yeah.
What's meaningful to her in this moment? And then does the family share that? Do they understand the same terminology? So it's kind of figuring out what is it they really want and need from a family side and a patient side.
And yeah, from the family is really, really important. Even with anointing of the sick or last rites from the Catholic perspective, some of them, as JD was talking about, wanting to have that that anointing, the anointing of the sick, right when they come on to our service. For some families, they don't want to scare the patient with that being performed by the priest. So there's an education piece in that. Sometimes I have them call the Catholic parish so that they can get direct education from the church rather than from me. But I try and be sensitive with and checking with them as I start to see somebody having greater decline. If they have not wanted to have anointing of the sick earlier on, I watch that patient a little bit more carefully and then try and communicate that with the family.
Anticipate it.
Yeah.
So from a Lutheran standpoint, kind of a step down from Catholicism, and then Presbyterian will have something depending on how organized the religion is.
Yeah.
And then to a general Christian standpoint, there's probably still a blessing, a prayer,
Yeah.
Let's see.
Yeah, and in between Lutheran and Presbyterian and Catholic would be Episcopal and Anglican. They would usually come out and do like anointing of the sick, or some type of anointing as well.
Sure.
And there are invisible rules too, right? Because high church, like Catholic or Episcopal, you can have a Catholic priest come and do that.
Okay.
A Catholic person would not want me to do that. Versus Lutheran, Presbyterian, some of those would be fine with any sort of pastoral figure.
The knowledge of that practice.
Yeah. So, and but even like Episcopalian, it would be okay sometimes with a Catholic priest, but not. So there's these like kind of views of
Sure.
how they view that kind of, and so for those high church people, it's more important who that person is.
And then we have a large community of Church of Jesus Christ of Latter-day Saints. So what kind of things are we thinking about for them?
Just referring to God as Father, and focusing on the eternal family, focusing on the connection of the family in the moment, and even with LDS people too, is making sure that somebody comes in to bless them too.
Sure. So there'll be a similar to the anointing of the sick, blessing of release.
I've reached out to like finding the ward nearest a facility, reached out to a bishop, and they've been wonderful. Like they're really responsive and will go out, and often that was comforting for the family in that instance, knowing that, especially because the family was out of town.
Yeah.
To know that a local representative from their church was going to be coming and visiting. And so that's one of those two where I think it's important to try and, if they have a clergy member or if they don't, and that would be meaningful, trying to find somebody.
We talked about temple garments earlier. So, they're going to want to be dressed in those, even if they get in the way. There are convalescent garments that are more like a nightgown or hospital gowns that tie in the back, and they can get those from their stake president. Okay.
Music too. I utilize music quite a bit with our patients.
Yeah.
And I've tried to research and ask families what hymns, depending upon their religious preferences, that are meaningful to them. And so I try and keep that in my repertoire and customize that depending on what their desires are.
And when in doubt, Amazing Grace.
Sometimes not, actually. And prayer was brought up, but just the way that
I'm saying the Church of Elvis.
that we
Let's talk about that.
Just the general prayer that we use. So I know that when we walk into a situation, if we know that they're not very high church, we know that they're going to want to pray later. Like we're listening the entire time, and we're kind of making mental notes of like, okay, so this is a concern, this is getting concerned, this is getting concerned. And so when it's time to pray, like we are all lifting that up, and from the second we walk in the door and making mental notes of what their concerns are to pray about that. And then, Drew mentioned, Episcopal, Anglican, and I think shares some same language, even Lutheran, like a great book or resource is the Book of Common Prayer.
Yes.
In that it's very general, and it reaches a lot of those Protestant Christian faith traditions. It's just a wonderful resource.
Cool.
Yeah.
So,
and for anybody listening, they just came out with an updated version of the Book of Common Prayer. So that's something that we're getting on board for our team as well. So that, we can utilize that with our patients.
Cool. So spirituality, or at least religion, less and less people are identifying with a religion, right, in the country. So what kind of rites, rituals might people have that are not based in a religion or faith?
So I wanted to say that I think it's important when we talk to the families that we speak really open and let them kind of give us information and so forth, because going on that fault, a lot of people will say that they're religious because they feel that they have to in order to get good care.
Interesting.
Yeah, because they feel like they have to say, and they might believe in God, but they have no religion, or they might be agnostic or atheist, but they'll just say, but even though that prayer will kind of make them uncomfortable. And then the other thing is when it comes to that they might have more spiritual preferences, which go with their family and their friends and their life experiences rather than anything you could find in the book.
So what kind of I'm actually trying to think of some myself, but can you guys think of any rites or rituals that may pop up in even our younger group, right? Our 20 and 30-year-olds with cancer?
People want to, sometimes the act of giving stuff away is a ritual.
Okay.
Them, making sure their loved ones get what they want them to have.
Cool.
People tend to cling to objects too. Like, that's why history is really interesting, because we look at artifacts, and they're an artifact because that describes that person. And so a person can be described by the things that they own and the things that they have.
Okay.
And so just understanding what's important to them, because it might be like a little metal heart to you, but that's really sentimental to them.
Yeah. Well, if you go to,
It might be a rock.
well, and if you go to like a combat vet, have you guys seen that black bracelet on Travis's left wrist? Right?
Yeah.
That will be with him until the day he dies. That's his buddy that died in combat.
Yeah, that's what I'm saying. So
Yeah.
some people just have objects.
Okay.
One of my patients, it was actually kind of for him. He sent out an email to all his family and friends saying, how did I impact your life? Or what do I need in your life? And so he's like, I wanted to see what impact I made before I passed. So everyone
that's
sent
cool.
all these emails and letters about memories and how he impacted their lives, and that was really important to him.
So tell me what you're going to say at my funeral before I get there. Right?
Yeah, exactly.
Okay.
So I can see if I want you to talk.
I just had one where they got a beer that they all enjoyed.
Okay.
Like a 6-pack, and they all drank a beer with the patient after he passes. Like, he obviously wasn't, but as a family, and they did like a cheers, and they just talked about like lots of times that they had with him. So that was kind of a ritual that they wanted to do.
Okay.
at
So
that time.
favorite beverage?
Yep.
Okay.
Yeah, I think reminiscing is kind of a universal. Like I've seen a bit of death visits where there's kind of this silence, and almost if you can start that, it can kind of change the feeling in that room where people start to share and start to, I think, begin that process by telling stories. And that feels like very natural. I feel like I've seen a lot of families that turn is beyond just like kind of what you're saying, beyond what you find in a book, but more just this desire to talk about that person.
Finding meaning in a person.
And for chaplains, one thing that we talk about a lot is meaning making with families. So providing purpose and meaning with the family and with the patient. And sometimes that comes with normalizing spiritual experiences. So they might see things in the room or have an experience when the patient passes. And if whether or not they have a theological context for that, sometimes it's disorienting to them. So to walk through with them what those things could be and make meaning out of that for them can provide a lot more peace.
Cool.
There was a 32-year-old gentleman that he came on for cancer, and within the last year, it was super quick. I mean, I saw him in the ICU, he was intubated, they extubated him, brought him home, and the girlfriend was his power of attorney, and he had a great family, but it was like, when I went to the home for the first time, it was like a party. Like, there was tons of family members there, everybody was in and out. They were playing rock music in his room with him, and it was like, not my music, but like, it was so fun being in there, because you could just tell that's what he wanted. He wanted that music playing. His family and his girlfriend were just, I mean, she did all the cares. She never had us do anything. It was just like, it was fun.
Yeah.
Everybody was eating together and just in and out of the room. And I mean, he passed within like 5 days when he got home, but it was cool.
I had a celebration of life.
Yeah.
Yeah.
I think what Travis and Zach do at, with the veterans honorings after they die, that's very much a ritual.
That's huge. Just
yeah. And I mean, if you look at, I don't know if you guys have looked at our Google reviews, but at least 50% of that has Travis or Zach involved in it.
Probably mentioned the uniforms too.
They do mention the uniforms. And the haircut, yeah. It's funny you mentioned beverages. If Mary goes before I do, we have to have a Diet, everybody has to raise a glass to a Diet Coke. let's see. You know, why don't we end there? Any final thoughts about those last few minutes, those last hours, anything that stands out to you guys, or a patient that you thought was, man, this was done right kind of thing?
I think like loving on the patient, you know, families really appreciate that, and the patient really appreciates that. They're like, how can this complete stranger come in here and love my mom? Or how can this complete stranger come in here and love me? And it's the feeling of love. You know, you don't even necessarily have to touch them, but people can sense that. People can sense your emotion.
And that's what makes a good, I mean, I'll say it broad in general, a good healthcare worker, right? If you have a physician that you know cares about you, you're going to have a better outcome. If you have a hospice nurse that shares a piece of them with the piece of yourself with that patient, they're going to have a better outcome. If you look at malpractice suits, I guarantee most of the malpractice suits start with that guy was a jerk, right? And so
one thing I was taught from when I was an aide is to still say their name, still explain what you're doing after you pass.
Thank you.
So I've always had that in my head.
So thank you for bringing that up. So when a patient's comatose, in case we couldn't hear you on the recording, always continue to use their name, always explain what you're doing. I find that my default is sir or ma'am rather than name, but that's just me. Try to avoid honey, sweetie, and sweetheart.
Even after they pass.
Even after they pass.
Yeah, I do that even after they pass, but still.
And you continue that communication of, okay, Bob, we're going to move you now. After they passed, we're going to move you onto the gurney.
Family really likes that, and they feel like you're still treating them as.
Yeah.
Well, it's just respectful. I mean, that's all there is to it. It's just showing respect for that person.
Yes. When you guys transfer, did you have something, Gary?
I did, but you can.
Go ahead.
I was just gonna say from the on-call perspective, I feel like I do a lot more deaths than everybody else.
The average Joe?
The average. But I found it's extremely important, especially for those people who don't have a system to fall back in, to step in the door and hand them a plan. To say, okay, this is what happens next, and then we do this, and then we do this, and then I'm gonna do this, and tell them exactly how things are gonna go as far as you can get them.
Okay.
Because quite often I'll walk into those situations, they have no idea what happens next. Even if Cody's told them or Carl's told them, and then in that moment, they're like,
Yeah, they could have heard it every day of the week, 5 times a day, right?
right.
And at that moment, they
So
forget everything.
going in there and just being confident and direct and say, okay, we're gonna do this, we're gonna do this. You know, once you get established, I mean, obviously if there's a tradition they're gonna follow, I move into that mode, but
Yeah.
if I feel there's nothing there, I start giving them the steps that we're gonna follow.
So I think something that I've seen that has allowed hospice people to be successful in hospice, they know when to take charge and know when not to, right? So the patient I had, the daughter was in internal medicine. She wanted to do the cleaning of the mouth. So I would open it and hand it to her like we were in surgery, right? And I was in the nurse support role for that physician, taking care of her grandpa. So I knew that I wasn't necessarily in charge. I made sure everything happened, but they were in charge. So in that situation though, where there's no plan, then you have to be that calming person, and that person's okay, here's the plan, here's what we're going to do. But in other situations, it may be the rabbi, it may be the imam, it may be somebody else who's in charge. Growing up on the reservation, it was medicine man, or the eldest, is usually the eldest female, but she let the male be in charge. So there's things that, and so Polynesians may be the same thing, right? If you're from the Polynesian culture, I am definitely not in charge when I walk in that room. So if you know when to take charge and when not to take charge, I think you can be really successful at that. There'll be times where I ask the family to step out while I move the body from the hospital bed to the gurney. Do you guys do that?
I do.
Sort of.
Yep.
I offer it.
I encourage it.
I always try to.
Well, and that's why I say you can do this, but I'd recommend against it.
Yeah. So, when we move, and I don't say this, but, there's times where maybe that funeral director isn't quite as strong as he thinks he is. And we slip a little bit. And we don't want that to be the last memory, right?
Oh, well, then the purge and everything else that can happen.
Things that can happen.
Yeah.
When we move the body, there's things that can happen.
It's funny because the family thought it was funny. But
Okay.
probably within this last year, I had this little lady with heart failure who died in the Meadows, and she had her back door had a little path right there to the little roundabout to get to the van. And it was a brand new mortuary person. It was her first run. She was by herself. I was like, it's fine. I'm there. The family was amazing. They were still there. We got her out, said our goodbyes, did this whole big thing, and then took her out. While we were trying to maneuver the gurney on the little pathways, I mean, we almost tipped her over 3 times. So the family was watching us this whole time. So in my mind, I'm like, okay, yeah, this is fine. It's going well. And then we get to the van and it's all right, goodbye. I said goodbye. I was like, all right, guys, I'll talk to you soon. And we could not get the gurney in the van. It literally for 20 minutes, we were trying to get the gurney in the van. And even one of the residents that was walking by tried to help us. And I was like, my God, this is so embarrassing. And the family is just looking out the window at what we're doing. And I'm like, okay, we need to make a plan. And the poor girl felt so bad. She was like, I don't know what's happening. We tried calling the other guy with funeral home. He's like, I can't be there for 20 minutes. And we're like, what? So we literally took her on the gurney back into the apartment. And I was just like, oh no. But we just sat there and laughed, and the family was like, she would do this. This is totally what she would do. And I'm like, oh, so just some of the things that can happen after.
Yeah. Do you guys, so I don't know about you, but when something doesn't go the way I plan, I find a real good way to say, wow, they're really tough. So something's just going wrong and you can't fix whatever's going on. And man, they're a fighter. Families like that. Yeah, she's been stubborn her whole life. And, but it does, bring some levity to a situation that sucks.
It lifts their spirits.
It does.
They just start oh my gosh, she would do that, wouldn't she?
Yeah.
Yeah.
And then they start telling you stories.
Right? Everybody does that, right? All of us have a stubborn piece in us.
Yeah.
And so sometimes you need to, I use that to my advantage a lot of times.
I think the one death that really stands out in my mind that went so perfect, I mean, it couldn't have happened any better, was me and you and Travis.
Oh yeah.
I mean, that was the most beautifulest thing to experience, the family gathering and their cohesiveness and their acceptance and things just flowed.
Yeah. So Carl you got there before I did, right?
Yeah, I was the first one.
And so Carl was already doing stuff and I walked in and the rest of the time I was pretty invisible. I sat in the back, I was destroying meds. Carl was doing his thing. When Travis came, I mean, everybody wanted Travis. But the wife kind of did everything and you and I went into the support role.
Yeah. Yeah. They wanted to do all the cleanup and everything. And so we just kind of assisted them and handed them things that they needed. And
he had a Hawaiian outfit that he went out with.
Yeah. His Hawaiian shirt.
Yeah. He had his Hawaiian shirt. That's where and his wife was from Hawaii.
Yeah. I mean, it just went so peaceful.
Yeah. Yeah. Agreed.
Those are the nice ones. I like that.
Yeah. Did you have anything, Trina? No? Okay. All right. We'll end there. All right. Thank you, everybody. That was the last one of the Stake Week course. We'll probably do it again in the fall. And you're welcome to come, or if you've already been to it, you don't have to listen to me talk again. All right. Have a great day, everybody.